picture the absolute frustration, right? You're holding the exact solution to this massive surgical problem. You've completely proven that it works, and the entire medical establishment just completely ignores you.
Oh, it's the classic tragedy in surgical history.
Right. So it's 1896. A surgeon named Tansini is tackling the brutal reality of breast cancer resections, and he recognizes that, you can't just leave a massive chest wall defect completely exposed.
You absolutely cannot.
Yeah. So he develops the latissimus dorsi flap. He meticulously maps out the blood flow, battles through all the inevitable trial and error of flap necrosis, and eventually he just nails the vascular anatomy.
He really did. He created a fully vascularized, totally reliable musculocutaneous flap to actually rebuild the chest. I mean, it was a monumental breakthrough, a genuine paradigm shift for chest wall reconstruction.
Right, but then there's William Halsted. Halsted essentially dominates the surgical world at this point, and his dogma was just absolute.
Oh, Halsted was an absolute giant. When he spoke, everybody listened.
Exactly. And he preferred using simple skin grafts or, even worse, healing by secondary intention.
Yeah.
Literally just leaving this massive open wound to slowly granulate and scar over from the bottom up over, months.
Which is just brutal for the patient.
It is.
Okay.
So because of Halsted's influence, Tansini's brilliantly engineered flap gets shoved in a drawer. I always think of it like this genius architectural blueprint just locked away while everyone else is out there building leaky roofs. It sits there basically ignored for nearly 80 years. Why did the medical community reject a better method for so long?
Well, entrenched dogma is a really powerful, dangerous thing in surgery. Halsted issued these strict admonitions against using flaps in cancer treatment. He primarily feared that thick tissue might hide local recurrences or that it would complicate the oncologic margins. So the surgical world just fell in line.
Wow.
Yeah, it actually took until the 1970s for Tansini to be truly vindicated.
Right, and that's when the modern giants stepped in. You had surgeons like Mathis, Nahai, and Bostwick finally proving the absolute superiority of muscle and myocutaneous flaps for mastectomy defect.
Yep, the true pioneers of the modern era.
And right alongside them, you had Arnold and Perolero. They started harnessing the external oblique, the pectoralis major, the latissimus, and the omentum to solve these major structural chest defects.
And that's really the mission of our deep dive today. They established this reconstructive toolkit that we completely rely on right now. Because whether you're managing, say, an acute trauma patient whose chest has been crushed, or you're dealing with the aftermath of an aggressive tumor resection, you are standing on their shoulders.
Absolutely.
But, before you can utilize any of those tools, you have to understand the framing of the house you're trying to rebuild.
Right, the structural foundation.
Yeah.
Which is essentially a cone, right?
Exactly. The chest wall is a cone. The apex at the top, the thoracic outlet, is defined by the first thoracic vertebrae, the first ribs, and the manubrium. Down at the base, you've got the diaphragm, the inferior ribs, the xiphoid process, and the lower spine.
So it's this rigid cage protecting everything vital.
It is, but here's the key point about the vascular supply. The plumbing supplying that cone is heavily redundant, which in real life is an absolute lifesaver.
Yeah.
Your primary flow comes from the paired intercostal arteries running off the aorta posteriorly. They travel forward to the intercostal spaces and join the internal mammary arteries, or IMAs, which run vertically down the anterior chest.
They form this massive vascular ring road.
A total ring road, and backing that up, you have secondary supply coming from above and the sides. So the subclavian and axillary systems, they feed the thoracoacromial, lateral thoracic, and thoracodorsal branches.
Okay, so a ton of backup flow.
Right. That redundancy is what allows us to confidently mobilize chest wall tissues without causing widespread ischemia.
And that robust anatomy is brilliant, until an outside force violently dismantles it. Let's look at the sheer physics of blunt trauma. In the U.S., motor vehicle accidents are the primary culprit tearing the structure apart.
Oh, definitely.
We see serious thoracic injuries in about 7% of all motor vehicle accidents, and the chest is involved in a fifth of all trauma deaths.
Yeah, the energy transfer in a high-speed collision causes chaotic, totally unpredictable skeletal defects.
Yeah.
I mean, the most terrifying presentation to witness in the trauma bay is a flailed chest.
That structural failure happens when you have, 3 adjacent ribs broken in 2 or more places?
Exactly. The chest wall literally loses its mechanical continuity.
I always think of it as a localized collapse of the building's framing. When the patient breathes in, The negative pressure inside the chest physically sucks that broken floating segment inward, and then when they breathe out, the positive pressure pushes it outward.
Right, the paradoxical motion.
Mm.
And that destroys their respiratory efficiency. Their pulmonary mechanics are fundamentally broken.
It's just devastating.
It really is.
Yeah.
Now, in real life, non-operative care is the gold standard for most isolated rib fractures. You optimize pain control, provide pulmonary toilet, and just let the bone heal. But a severe flail chest requires intervention.
Right. You can't just leave a massive segment of the chest caving in on the lungs with every single breath.
You really can't. You have to restore the rigid mechanics. So we use rigid rib plating systems now. Standard titanium plates, screws, and intermedullary rods that go right inside the marrow cavity. We physically bridge the fractured segments to recreate that rigid structural integrity the lungs absolutely need to expand.
That mechanical stabilization makes total sense for trauma. But tumor extirpation creates a very different kind of defect, right?
Completely different.
Because when an oncologic surgeon removes an aggressive breast carcinoma or like a massive soft tissue sarcoma, they are intentionally excising the healthy tissue margins. We're talking about resecting 4 or more ribs or leaving a full thickness defect greater than 5 centimeters across.
And classic surgical teaching mandates that any defect of that magnitude, particularly an anterior defect, requires skeletal reconstruction. You've got this massive void directly exposing the heart and the great vessels.
Which leads us to one of the most intense historical answers to that void, the methylmethacrylate sandwich.
The sandwich, yes.
You literally mix up methylmethacrylate, basically bone cement. You mold it into a custom plate that matches the shape of the missing chest wall, and then you sandwich it between 2 layers of synthetic Marlex or Prolene mesh. Then you suture that rigid plastic and cement shield directly into the surrounding rib stumps.
It creates a totally impenetrable barrier over the thoracic cavity.
Wait, I have to stop you there. You're putting a rigid block of cement into a cage that physically has to expand and contract to function. Doesn't that cause massive problems? The ribs pivot and swing up when we inhale. If you bolt a heavy, inflexible cement block into the middle of that system, you're completely arresting the natural motion of those surrounding joints.
It's a profound mechanical compromise. You're absolutely right. Patients frequently experience chronic pain with respiration because that cement block just refuses to yield when the rest of the chest tries to move.
That sounds miserable.
It can be, but this goes straight to the brutal trade-offs we have to make in surgery. Leaving a massive anterior void means the heart is completely unprotected from everyday physical contact. And worse, the chest will physically cave in, which causes respiratory failure. So the painful rigidity of bone cement is basically the price of keeping the patient alive and their vital organs shielded.
That makes sense. But the location of the defect really dictates how aggressive you get with those synthetic materials, right? You certainly do not want a synthetic mesh like Prolene anywhere near the lower chest or lateral margins.
Common pitfall right there.
Yeah.
If you place synthetic mesh low on the chest wall, it frequently comes into direct contact with the intra-abdominal contents right below the diaphragm.
And the human body hates foreign synthetic material touching the bowel. It incites a massive inflammatory response, which leads directly to dense adhesions or, even worse, catastrophic bowel fistulae.
Exactly. The bowel essentially erodes right into the mesh. It's a nightmare. That is why biologics are taking over for areas where absolute bulletproof rigidity isn't mandatory. We use human allograft dermis or xenograft dermis. They're much softer, they yield to the respiratory mechanics, and critically, they do not provoke visceral adhesions.
And physiologically, biologics offer something a piece of plastic never could. They actually revascularize. The patient's native blood vessels grow directly into the collagen matrix of the graft. It becomes living tissue again.
Which is their absolute superpower. A revascularized biologic graft can actively fight off bacterial contamination. A synthetic mesh is just a dead avascular scaffold. If bacteria seed a piece of Prolene, the infection will never clear until you physically, surgically explant the mesh.
And that perfectly sets up the nightmare scenario. We've covered physical structural voids. But what happens when the cavity itself turns into a massive, uncontrolled biological hazard? Because intractable deep space infections completely change the reconstructive algorithm.
Oh, they test every single skill you have. Look at the pleural space. Say a patient undergoes a pneumonectomy to resect lung cancer. The entire lung is gone, leaving a massive empty cavity. If the sutured bronchial stump breaks down, you get a bronchopleural fistula.
Right.
The airway is now openly communicating with that empty space. It rapidly fills with pus, creating a massive empyema.
The historical attempts to solve that specific disaster were incredibly grueling. In 1935, Leo L. Lesser described a highly specific flap to drain tuberculous empyemas. He would design a U-shaped, random pattern flap of skin and fascia, resect a segment of underlying rib, fold the flap into the chest, and sew it directly to the infected pleural lining.
He was literally creating a permanent epithelialized blowhole into the chest cavity, just so the pus could drain out onto the skin indefinitely.
It's wild to think about. And later came the Chlorregate procedure, which is arguably even more labor-intensive. You create a window thoracotomy, basically an intentional hole in the chest wall, and manually pack the infected cavity with dressings soaked in antibiotics. You bring the patient back to the OR or do it right at the bedside, changing those massive wet-to-dry dressings every 48 hours for weeks until the entire cavity is lined with healthy red granulation tissue.
And then you flood the space with an antibiotic solution and finally close the skin.
Right. Both of those sound medieval.
They do, but you have to compare them to the standard of the time, which was the thoracoplasty. Before we understood how to manage dead space with healthy tissue, surgeons would intentionally perform a thoracoplasty. They'd meticulously resect multiple ribs to systematically collapse the skeletal framework. You forcefully crush the entire hemithorax down just to obliterate the empty space,
Leaving the patient with a severe, permanent, crushing deformity.
highly disfiguring. Thankfully, we don't have to break the skeleton to close the space anymore. Today, we utilize regional flap transposition. We dissect out massive volumes of healthy vascularized muscle, bring it directly into the pleural space, patch the leaking bronchial stump, and physically fill that dead space with living, fighting tissue.
And that same principle applies to the anterior chest, specifically adult sternal wounds following cardiac surgery. The historical context here is incredibly grim. Decades ago, developing mediastinitis, a deep sternal wound infection, carried a mortality rate hovering around 70%. Today, it's under 5%.
And that survival rate flipped almost entirely because plastic surgeons started bringing vascularized flaps to the sternum. But you really have to stage the problem correctly. We categorize these sternal wounds by timeline and severity.
Okay, break that down for us.
Sure. Class 1 infections are early, happening 1 to 3 days post-op. It's usually just thin, serious fluid weeping from the wound, and the cultures come back sterile.
Okay, so fairly mild. But class 2 presents 1 to 3 weeks out. This is the classic fulminant infection. You have actual purulent drainage, exposed bone, and positive bacterial cultures.
Right. And then class 3 is the chronic phase, presenting months or even years later.
Yeah.
The acute infection burned out, but the patient develops a chronic draining sinus tract that tunnels all the way down to a piece of infected sternal wire or necrotic bone cartilage.
There's a critical anatomical variable that drives a massive number of these sternal infections, and it all traces back to the cardiac surgeon's bypass strategy. A coronary artery bypass graft, or CABG, often utilizes the internal mammary arteries as the bypass conduits.
Yeah.
If the cardiac team harvests both the left and right IMAs, the sternum faces an immediate existential threat. But wait, if the cardiac surgeon takes both IVAs for the bypass, how does the sternum not just immediately die?
It's a great question, and it highlights a devastating anatomical vulnerability. Most major bones in the body have a medullary blood supply.
Yeah.
Large nutrient artery running right through the center of the marrow. The sternum does not. It relies entirely on a peristeel plexus, which is a tight vascular net wrapped around its outer surface. And that critical surface net is fed directly by tiny segmental branches coming off the IMAs.
So the moment the cardiac surgeon clips and removes both IMAs,
the primary blood pressure to the sternum plummets to near zero. Now, it doesn't undergo immediate total necrosis because a tiny trickle of collateral flow comes from the intercostal muscles, but it becomes incredibly ischemic. And a bone with no blood supply cannot heal a fracture.
And a median sternotomy is essentially a massive iatrogenic fracture.
Exactly. So the risk of non-union and deep mediastinitis just skyrockets.
This is where surgical engineering steps in to assist the biology. Titanium sternal plating.
It is an absolute game changer for these high-risk bilateral IMA patients. Standard wire circlage, basically just wrapping steel wires around the bone, allows for subtle shifting and grinding when the patient coughs. That micromotion destroys the fragile capillary beds trying to cross the fracture line. Titanium plates apply rigid osteosynthesis. They lock the bone halves together so tightly that micromotion drops to zero.
And less micromotion equals successful bone healing, which locks out the bacteria.
Right.
But if the infection has already destroyed the bone and the soft tissue, we have to rebuild. The rigid structure is stabilized, the infection is debrided, and now you're staring at a massive empty crater over the heart. You have to open the reconstructive tool belt, the workhorse flaps,
You need tissue with a massive, reliable blood supply.
and the options really dictate the strategy. I like to think of it this way. The pectoralis major is the reliable hammer you use for the upper half of the problem. The rectus abdominis is the extension ladder you pull up from the basement. And the omentum is the massive, adaptable tarp you throw over the most complex, irregular disasters.
I love that. That analogy holds up perfectly in the OR. Let's start with the hammer. The pectoralis major is the ultimate workhorse for sternal reconstruction, simply because it's right there. It borders the defect. Its dominant blood supply is the thoracoacromial artery coming off the axillary system. You elevate it, advance it medially, and fill the defect.
But the geometric limitation is pretty strict, right? The pec major pivots from the shoulder, meaning it physically cannot reach down to cover the lower third of the sternum or the xiphoid.
Correct. If you forcefully stretch it, the distal muscle will either tear or necrose. However, there's a brilliant workaround if the cardiac surgeon left the IMA intact on that side. You can design a turnover flap.
Oh, right.
You base the pec major entirely on the IMA perforators popping through the chest wall, cut its attachment to the arm, and literally flip the entire muscle over, like turning the page of a book. That puts the bulk of the muscle right over the lower sternum.
That's incredibly clever. But if the IMA is gone, that page turn is impossible. So you reach for the extension ladder, the rectus abdominis. You take one of the six-pack muscles from the abdomen and rotate it up into the chest. It's naturally fed by the superior epigastric artery, which crucially is just the terminal continuation of the IMA.
Which brings us right back to the cardiac surgeon's choices. If the IMA was harvested for the bypass, the superior epigastric artery is dead. The rectus flap suddenly loses its powerful top-down blood supply.
But it has a backup system, right? The bottom-up flow.
It does. It can theoretically survive on retrograde flow through the 8th intercostal vessels branching off the musculophrenic artery. But in real life, pushing the rectus to survive on that secondary flow is a massive gamble.
Really?
Because the distal tip of that muscle, which is the exact part you need to reach the top of the sternal wound, becomes highly unreliable and prone to ischemic necrosis.
Okay, so when the local muscles are compromised, you have to break into the abdomen for the ultimate filler, the omentum, this massive apron of fat and blood vessels hanging off the stomach.
It's an incredible tissue. It's highly vascular, immunologically active, and incredibly pliable. You perform an upper laparotomy, enter the abdomen, and mobilize it off the transverse colon. You carefully divide the short gastric arteries to stretch it out, ideally basing the entire apron on the left gastroepiploic artery. That specific pedicle provides the absolute maximum reach.
Then you tunnel it up through the diaphragm. I mean, it can blanket the entire sternum, snake into deep, irregular pockets, wrap securely around exposed aortic grafts, and it's so vascular you can actually slap a split-thickness skin graft directly on top of it.
It solves the local chest problem beautifully, but the physiological toll on the patient is severe. Think about the clinical scenario. This patient is already critically ill. They're battling a sternal infection.
Yeah.
Their heart is compromised.
Right.
And you're now forcing them to undergo a laparotomy, exposing them to the risks of bowel injury, severe postoperative adhesions, and massive epigastric hernias down the road.
It's a phenomenal salvage tool, but the collateral damage is very real. You also have the latissimus dorsi, based on the thoracodorsal artery in the armpit. It brings a huge volume of muscle and skin, making it perfect for massive lateral or anterolateral defects. But deploying it for a central sternal wound is a logistical nightmare.
It requires extreme spatial coordination. The patient is lying supine, face up, with an open chest wound. To harvest the latissimus, the anesthesia and surgical teams have to physically roll this critically ill patient onto their side or stomach, maintain airway and hemodynamic stability, harvest the flap from the back, and then roll them onto their back again to inset the flap into the chest.
A truly precarious dance. Now, managing these massive defects in pediatric patients introduces an entirely different set of rules, doesn't it? You're dealing with anatomy that hasn't finished forming.
Absolutely. The debridement phase is where most errors happen. A child's sternum and costal cartilages are heavily unossified. They're mostly soft cartilage. If you aggressively debride a pediatric sternal infection with the same force you use on an adult, you will inadvertently resect their future skeletal framework.
Well, that's terrifying.
And when it comes to coverage, their omentum is usually paper thin. It lacks the fatty bulk needed to fill a deep sternal void.
And the pectoralis major becomes a high-risk option, specifically in female pediatric patients.
You really have to avoid it if at all possible.
Hmm.
The developing breast bud sits directly on the fascia of the pectoralis major. If you elevate that muscle to cover the sternum, you will inevitably damage or displace that breast bud, causing severe breast hypoplasia or total developmental failure later in life.
Which leaves the rectus abdominis as the hero for infants and children. It's predictably wide, thin enough to not look overly bulky, and highly reliable. Now, before we leave the topic of acquired defects, we have to look at the intersection of chest wall reconstruction and advanced cardiac hardware, left ventricular assist devices, or LVADs.
These mechanical pumps are keeping end-stage heart failure patients alive. They used to be just a temporary bridge to transplant, but now patients live at home with them for years as destination therapy.
And just like an artificial joint or a pacemaker, an LVAD is a massive piece of foreign hardware sitting in the chest, which means it can get infected. The infection usually starts superficially at the driveline, the external power cable exiting the skin of the abdomen, and it tracked all the way deep into the LVAD pocket itself.
And the fundamental rule of infected surgical hardware is that you must remove the hardware to clear the infection. But you cannot explant an LVAD. That pump is the only thing maintaining their cardiac output. Unless a donor heart is literally waiting in the next room, removing the device equals death.
So you have to save the device in place. You aggressively debride the infected capsule around the pump and bring in a highly vascularized flap, typically the omentum or the rectus abdominis, to obliterate the space and wrap the hardware. But there is a massive trap hiding in the abdominal wall.
The driveline routing. When the cardiac team initially implants the LVAD, they often tunnel the power cable directly through the belly of the rectus abdominis muscle to secure it.
So the very muscle you desperately need to use as a rescue flap has a thick power cable permanently cored through its vascular territory.
Exactly. Attempting to harvest that rectus muscle might destroy the superior epigastric pedicle entirely. It requires hypervigilant preoperative planning. It's a surgical minefield. You have to assume the local tissue architecture is heavily compromised.
We've spent a lot of time on chests destroyed by trauma, tumors, and bacteria, but fixing a chest that never formed correctly in the first place requires a completely different architectural approach. Let's examine congenital deformities. The ones that dominate clinical practice are the pectus deformities.
Right. Pectus carinatum and pectus excavatum. Carinatum is the outward protrusion of the sternum and costal cartilages. It's often referred to as pigeon chest. Excavatum is the exact opposite, a profound concavity where the sternum sinks deeply inward toward the spine. We see excavatum heavily associated with inherited connective tissue disorders like Marfan syndrome or Ehlers-Danlos.
And the critical realization with severe pectus excavatum is that it's absolutely not just a cosmetic issue. It is a profound hemodynamic problem. When the sternum is driven backward into the mediastinum, it physically squishes the right ventricle of the heart and restricts pulmonary expansion.
The physiological data is undeniable. When you put these patients on a treadmill, you see measurable decreases in their cardiac stroke volume and their forced expiratory volume. The heart simply does not have the physical room to fill with blood before it pumps.
Restoring that room requires major structural engineering. You have two primary approaches. The traditional open approach is the Ravitch procedure. You make a wide incision, radically excise the deformed, overgrown costal cartilages, and physically cut through the sternum in osteotomy to break its malposition angle. You bend it forward into a normal position and buttress it with mesh or struts.
It's highly effective but incredibly invasive. That is why the noose procedure completely revolutionized this space.
Yeah, tell us about that.
The noose is a closed, minimally invasive technique. You use thoracoscopy, a camera inside the chest, to carefully slide a custom-bent, convex titanium bar completely behind the sunken sternum.
Then comes the mechanical lever action. The bar goes in concave side up, perfectly matching the dented chest. Once it's safely across, you use a special tool to forcefully rotate the bar 180 degrees. As it flips, the convexity pushes outward, physically prying the crushed sternum off the heart with immense mechanical force.
It's wild to watch. You secure the bar to the lateral ribs and leave it locked in the chest for up to 5 years. The constant outward pressure forces the skeletal cartilage to slowly remodel and harden into its new expanded shape. Pulling that weight off the right ventricle triggers an immediate, profound improvement in the patient's cardiac output and exercise tolerance.
It's just brilliant biomechanics. The final congenital anomaly to examine is Poland syndrome. It's incredibly rare, showing up in about 1 in 16,500 births. These patients present with a very specific unilateral absence of anatomy. The classic presentation is this severe hypoplasia or total absence of the sternal head of the pectoralis major. They might also be completely missing their latissimus dorsi.
And the underlying bone and rib cartilage on that side is often severely underdeveloped.
That's right.
From a reconstructive standpoint, the most complex element is that the breast and nipple areolar complex on the affected side are often severely hypoplastic or entirely absent.
Right, so the reconstructive algorithm is highly gender dependent. For male patients presenting with a missing pec muscle, the primary goal is restoring the muscular contour of the chest. We often use customized solid silicone implants designed from a 3D CT scan to perfectly mimic the volume of the missing pectoralis. But for female patients, you have to recreate a natural ptotic breast on a chest wall that has no foundational soft tissue.
It requires a meticulously staged approach. You're typically starting with tissue expanders to slowly stretch the tight skin, eventually swapping them for permanent silicone implants. But the implant alone cannot solve the architectural void. A natural breast requires symmetry, appropriate projection, and natural breast ptosis, the subtle natural droop of the tissue.
And you cannot achieve natural breast ptosis if you don't have an anterior axillary fold. In Poland syndrome, because the pectoralis major is missing, the front border of the armpit is just a flat void. The implant looks completely artificial because there's no muscle wrapping around it.
Exactly. To recreate that vital axillary fold and provide a thick, healthy layer of soft tissue over the implant, we frequently mobilize a latissimus dorsi myocutaneous flap from the patient's back. It sweeps around the side and beautifully reconstructs the missing upper chest contour.
But wait, you noted earlier that patients with Poland syndrome are frequently missing their latissimus dorsi as well.
They are, and if you image the patient and realize the latissimus is absent or too hypoplastic to use, you've lost your only reliable local flap. At that point, you have to pivot to advanced microsurgery. You perform a free tissue transfer. You harvest a completely independent block of tissue, like a DIP flap from the abdomen or an ALT from the thigh, bring it up to the chest, and meticulously sew the tiny blood vessels together under a microscope to build a new chest wall entirely from scratch.
The evolution of these techniques is staggering. We started with Tansini fighting to prove the viability of a single latissimus flap back in 1896, painstakingly mapping the vascular network that makes all of this possible. We broke down the sheer physical violence of flail chests and the mechanical trade-offs of the methylmethacrylate sandwich.
We examine the brutal history of managing dead space, moving from the destructive collapse of thoracoplasties to the life-saving precision of bringing revascularized tissue to an infected sternum.
And we mapped out the reconstructive tool belt, understanding exactly why the pectoralis, the rectus, and the omentum behave the way they do, based purely on their intricate vascular plumbing. Whether you're using a Nussbar to pry a crushed sternum off a beating heart or tunneling omentum up to save an infected LVAD, it all comes back to respecting the anatomy.
You really cannot rebuild the structure if you do not understand the foundation.
It really forces you to look at the horizon. We're currently utilizing biologic meshes that actively revascularize and custom 3D printed titanium implants that integrate perfectly with native bone. As we push the boundaries of lab-grown tissues and advance negative pressure wound therapies, it makes you wonder, are we approaching a future where surgically sacrificing our own core muscles, like taking a rectus or a latissimus, will be viewed as barbaric? Or will the human body's own dynamically vascularized tissue forever remain the absolute gold standard for fighting off devastating infections? Just something to think about the next time you're staring down a complex defect. Until next time.